Welcome to this ultimate NCLEX practice session. In today's video, we're tackling 50 of the most difficult NCLEX questions on lab values. These aren't your regular review questions, they are designed to push your critical thinking to the highest level. Each question is followed by a detailed rationale and a test-taking strategy, so you not only learn the correct answer but also understand the reasoning behind it. Lab values are one of the most tested areas on the NCLEX, and success often depends on your ability to recognize what's normal, what's critical, and what action the nurse should take immediately. By the end of this session, you'll be more confident in interpreting labs and prioritizing care based on what they reveal. So grab your notebook, focus, and let's dive in. Question 1. A patient with acute pancreatitis is admitted with severe abdominal pain. Labs show amylase 540U/L, lipase 1180U/L, alt 80U/L, and bilirubin 2.1 mg per deciliter. Which lab finding is the most significant indicator of pancreatitis? A. Amylase 540U/L. B. Lipase 1180U/L. C. Alt 80U/L. D. Bilirubin 2.1 mg per deciliter. Answer: B. Lipase 1180U/L. Rationale: both amylase and lipase are elevated in pancreatitis, but lipase is more specific and remains elevated longer than amylase. Elevated alt and bilirubin may indicate biliary obstruction but are not as specific for pancreatitis. Strategy: for pancreatitis, always prioritize lipase because it is the most reliable and disease-specific marker compared to amylase. Question 2. A patient on 4-heparin therapy for a DVT has an APTT of 115 seconds. What is the nurse's best action? A. Continue the infusion at the current rate. B. Hold the infusion and notify the healthcare provider. C. Document this as therapeutic and recheck in 6 hours. D. Increase the heparin infusion rate. Answer: B. Hold the infusion and notify the healthcare provider. Rationale: the therapeutic APTT for patients on heparin is about 1.5 to 2.5 times normal, 60 to 80 seconds. An APTT of 115 is dangerously high and indicates a significant bleeding risk. The infusion must be held until adjustments are made. Strategy: for anticoagulation questions, always compare the lab value with the therapeutic target range before deciding if it's safe to continue or stop therapy. Question 3. A patient with chronic kidney disease has potassium of 6.7 milliequivalents/L. Which ECG change is most consistent with this lab finding? A. Flattened T waves. B. U waves. C. Tall peaked T waves. D. ST segment depression. Answer: C. Tall peaked T waves. Rationale: hyperkalemia, greater than 5.0 milliequivalents/L, produces tall peaked T waves, prolonged PR interval, and widened QRS complexes. These changes can progress to life-threatening arrhythmias like ventricular fibrillation. Strategy: remember, high potassium equals tall peaked T, low potassium equals U waves plus flattened T waves. Calcium primarily affects QT interval duration. Question 4. A patient with suspected SIAD presents with the following labs: serum sodium 122 milliequivalents/L, serum osmolality 260 mosm/kg, urine osmolality 500 mosm/kg. Which finding best confirms SIADH? A. Serum sodium 122 milliequivalents/L. B. Serum osmolality 260 mosm/kg. C. Urine osmolality 500 mosm/kg. D. All of the above. Answer: D. All of the above. Rationale: SIAD is characterized by water retention, leading to dilutional hyponatremia, low serum sodium, decreased serum osmolality, and inappropriately concentrated urine, high urine osmolality. Strategy: look at all three indicators together. Low Na plus low serum osmolality plus high urine osmolality equals classic SIAD picture. Question 5. A patient with COPD presents with confusion. ABG results are pH 7.29, PaCO2 62 mm of mercury, HCO3 27 milliequivalents/L. How should the nurse interpret this? A. Metabolic alkalosis. B. Metabolic acidosis. C. Respiratory alkalosis. D. Respiratory acidosis. Answer: D. Respiratory acidosis. Rationale: the pH is low, acidosis, and PaCO2 is high, indicating retention of CO2. This is consistent with respiratory acidosis, often seen in COPD exacerbations. Bicarbonate is slightly elevated, indicating partial renal compensation. Strategy: use ROM, respiratory opposite, metabolic equal PaCO2 up, pH down, respiratory acidosis. Question 6. A patient receiving digoxin therapy has potassium of 2.9 milliequivalent/L. Which complication should the nurse anticipate? A. Reduced digoxin toxicity. B. Increased risk of digoxin toxicity. C. No effect on digoxin. D. Hyperkalemia from digoxin. Answer: B. Increased risk of digoxin toxicity. Rationale: hypokalemia increases digoxin binding to myocardial tissue, raising the risk of digoxin toxicity, arrhythmias, nausea, visual disturbances. Strategy: always evaluate potassium status when patients are on digoxin. Low potassium equals dangerous combination. Question 7. A patient with cirrhosis has labs, INR 3.4, albumin 2.0 g/dl, bilirubin 4.8 mg per deciliter. Which lab is most directly responsible for the patient's bleeding risk? A. INR 3.4. B. Albumin 2.0 g/dl. C. Bilirubin 4.8 mg per deciliter. D. AST 85 U/L. Answer: A. INR 3.4. Rationale: an elevated INR reflects impaired synthesis of clotting factors by the liver, leading to a high risk of bleeding. Albumin and bilirubin are markers of liver function, but INR directly correlates with coagulation status. Strategy: in liver disease, always assess INR to evaluate bleeding risk. Question 8. A patient on TPN has phosphate 1.7 mg per deciliter. Which clinical finding is most concerning? A. Tremors. B. Muscle weakness and respiratory distress. C. Polyuria. D. Constipation. Answer: B. Muscle weakness and respiratory distress. Rationale: hypophosphatemia, less than 2.5 mg per deciliter, impairs ADP production, leading to muscle weakness, respiratory failure, hemolysis, and impaired cardiac contractility. Strategy: always connect low phosphate, low energy, ADP, weak muscles and risk of respiratory collapse. Question 9. A trauma patient has a lactic acid of 6.5 millimoles per liter. What does this indicate? A. Effective tissue perfusion. B. Metabolic alkalosis. C. Inadequate tissue perfusion/possible shock. D. Normal response to trauma. Answer: C. Inadequate tissue perfusion/possible shock. Rationale: normal lactate is 2. High lactate indicates anaerobic metabolism due to hypoperfusion or hypoxia, commonly seen in sepsis or shock. Strategy: elevated lactate equals red flag for tissue hypoxia. Requires rapid intervention, fluids, oxygen, perfusion support. Question 10. A patient on warfarin has an INR of 5.5 but no active bleeding. What is the most appropriate intervention? A. Hold warfarin and administer vitamin K as ordered. B. Continue warfarin at the same dose. C. Stop warfarin permanently. D. Administer heparin instead. Answer: A. Hold warfarin and administer vitamin K as ordered. Rationale: INR 5 indicates dangerously thin blood. Vitamin K helps reverse warfarin's effects, preventing spontaneous bleeding. Strategy: for high INR without bleeding, hold warfarin and give vitamin K. For high INR with bleeding, add fresh frozen plasma. Question 11. An oncology patient has an absolute neutrophil count, ANC, of 180/L. Which action is highest priority? A. Start broad-spectrum antibiotics immediately. B. Place patient on neutropenic precautions and notify provider. C. Encourage visitors and family to visit freely. D. Resume chemotherapy as scheduled. Answer: B. Place patient on neutropenic precautions and notify provider. Rationale: ANC 500/L, and especially less than 200, indicates severe neutropenia and high infection risk. Protecting from exposure and notifying provider for further interventions, possible antibiotics, growth factors, is essential. Strategy: for severe neutropenia, infection prevention, reverse isolation, immediate communication with provider, and assessment for fever/infection are top priorities. Question 12. A patient with suspected bacterial meningitis has CSF results, WBC 1200/L, neutrophil predominance, glucose 20 mg per deciliter, serum glucose 110, protein 250 mg per deciliter. Which is the best interpretation? A. Viral meningitis. B. Bacterial meningitis. C. Subarachnoid hemorrhage. D. Normal CSF. Answer: B. Bacterial meningitis. Rationale: bacterial meningitis typically shows high neutrophilic pleocytosis, low CSF glucose, due to bacterial consumption, and markedly elevated protein. Viral meningitis often shows lymphocytic predominance and normal/near normal glucose. Strategy: in suspected meningitis, low CSF glucose plus high neutrophils equals treat empirically for bacterial meningitis while awaiting culture. Question 13. A patient with acute coronary syndrome has troponin I elevated at 0.12 nanograms per milliliter, previous baseline 0.03. CKMB is normal. What should nurse do next? A. Ignore troponin, CKMB is definitive. B. Notify provider and correlate clinically, troponin rise indicates myocardial injury. C. Discharge patient, CKMB is normal. D. Wait 48 hours before repeating labs. Answer: B. Notify provider and correlate clinically, troponin rise indicates myocardial injury. Rationale: troponin is more sensitive and specific for myocardial injury than CKMB. A rise from baseline suggests acute injury, clinical correlation and serial troponins are needed. Strategy: use trends in troponin and clinical signs, ECG, chest pain, to guide management, do not rely solely on CKMB. Question 14. ABG, pH 7.48, PaCO2 30 mm of mercury, HCO3 22 milliequivalent/L. What is the primary disorder? A. Metabolic acidosis. B. Respiratory alkalosis. C. Metabolic alkalosis. D. Respiratory acidosis. Answer: B. Respiratory alkalosis. Rationale: elevated pH with low PaCO2 indicates respiratory alkalosis. HCO3 is near normal/low due to renal compensation if chronic. Strategy: identify primary by pH and PaCO2 direction, respiratory opposite, pH up, PaCO2 down, respiratory alkalosis. Question 15. A patient with Addison's disease has NA 124 milliequivalent/L, K 5.9 milliequivalent/L, and orthostatic hypotension. Which intervention is most likely needed? A. Fluid restriction. B. Glucocorticoid and mineralocorticoid replacement per provider. C. Start loop diuretics. D. Administer insulin and glucose. Answer: B. Glucocorticoid and mineralocorticoid replacement per provider. Rationale: primary adrenal insufficiency, Addison's, causes hyponatremia, hyperkalemia, and hypotension due to aldosterone deficiency. Replacement therapy restores volume and electrolyte balance. Strategy: recognize the electrolyte pattern, low Na, high K, and link to adrenal insufficiency. Prioritize hormone replacement per orders and treat hypotension/supportively. Question 16. A patient with acute rhabdomyolysis has CK 14,000 U/L and dark urine. Which lab abnormality will be most concerning? A. Hypokalemia. B. Hypercalcemia. C. Hyperkalemia and rising creatinine. D. Low BUN. Answer, C. Hyperkalemia and rising creatinine. Rationale, muscle breakdown releases potassium and myoglobin. Myoglobinuria can cause acute kidney injury, rising creatinine. Hyperkalemia is immediately life-threatening. Strategy, monitor renal function, urine output, K+, and treat hyperkalemia and prevent/treat AKI. For fluids, alkalinize urine if ordered. Question 17. A patient on prolonged furosemide therapy has Mg 1.2 mg per deciliter, low. Which additional abnormality commonly coexists and should be checked? A. Hyperkalemia. B. Hypokalemia and hypocalcemia. C. Elevated BNP. D. Increased hematocrit. Answer, B. Hypokalemia and hypocalcemia. Rationale, loop diuretics cause urinary losses of Mg and K. Hypomagnesemia can also lead to refractory hypokalemia and hypocalcemia. Strategy, when Mg is low, always check K and Ca, replace Mg to help correct refractory hypokalemia. Question 18. A patient has serum osmolality 305 mosm/kg, NaL 148 milliequivalent/L, and glucose 320 mg per deciliter. What best explains the osmolality? A. Hypernatremia alone. B. Hyperglycemia contributing to elevated osmolality. C. SIAD. D. Hypoglycemia. Answer, B. Hyperglycemia contributing to elevated osmolality. Rationale, serum osmolality equals 2 Na plus glucose/18 plus BUN/2.8. Elevated glucose, 320/18 almost equals 17.8. Increases osmolality despite near high Na. Hyperglycemia causes hyperosmolar state. Strategy, always calculate contributors, Na, glucose, BUN, when osmolality and sodium seem discordant. Question 19. A patient with suspected DIC has platelet count 40,000/L, fibrinogen 80 mg per deciliter, and D-dimer elevated. Which immediate action is most appropriate? A. Begin empirical antibiotics only. B. Provide blood products, FFP, cryoprecipitate, platelets, per bleeding/ordering and treat underlying cause. C. Start heparin without addressing bleeding. D. No intervention, recheck tomorrow. Answer, B. Provide blood products, FFP, cryoprecipitate, platelets, per bleeding/ordering and treat underlying cause. Rationale, DIC consumes clotting factors and platelets causing bleeding. Replace deficient factors and platelets when bleeding and treat the trigger, sepsis, obstetric catastrophe. Heparin may be used in certain thrombotic-dominant DIC but is not first line when active bleeding and severe factor depletion exist. Strategy, manage DIC by simultaneously treating the underlying cause and supporting coagulation with appropriate blood products. Question 20. A postoperative patient's BUN/CR ratio increases from 12:1 to 28:1 with low urine output. Most likely cause? A. Intrinsic renal failure. B. Prerenal azotemia from hypovolemia. C. Postrenal obstruction. D. Lab error. Answer, B. Prerenal azotemia from hypovolemia. Rationale, BUN/CR 20:1 with oliguria suggests prerenal causes, decreased perfusion/hypovolemia. Intrinsic renal disease usually shows lower BUN/CR ratio. Strategy, assess volume status, orthostatics, and consider fluid resuscitation to restore renal perfusion if appropriate. Question 21. A patient with suspected heparin-induced thrombocytopenia, HIT, shows platelet drop from 320K to 90K on day 7 of heparin therapy. What is the appropriate immediate action? A. Continue heparin and watch. B. Stop all heparin products and start a non-heparin anticoagulant, e.g., argatroban, per protocol. C. Give platelets immediately. D. Administer aspirin. Answer, B. Stop all heparin products and start a non-heparin anticoagulant, e.g., argatroban, per protocol. Rationale, HIT is an immune-mediated prothrombotic state. Heparin must be stopped immediately and alternative anticoagulation started. Platelet transfusion is generally avoided unless bleeding. Strategy, recognize timing, 5 to 10 days post-heparin, and magnitude of platelet drop, act quickly to prevent thrombosis. Question 22. A patient with suspected hyperthyroidism has TSH less than 0.01 IU/ml, free T4 normal, and palpitations. Which is the best interpretation? A. Overt hyperthyroidism. B. Subclinical hyperthyroidism. C. Hypothyroidism. D. Euthyroid sick syndrome. Answer: B. Subclinical hyperthyroidism. Rationale: low TSH with normal free T4 suggests subclinical hyperthyroidism. If symptomatic, palpitations, treatment or further evaluation may be warranted, especially in elderly or cardiac patients. Strategy: don't rely only on TSH, correlate with symptoms and consider treatment risk/benefit. Question 23. A patient's fasting lipid panel shows triglycerides 1,600 mg per deciliter. Which acute complication is most likely? A. Aortic dissection. B. Acute pancreatitis. C. Pulmonary embolism. D. Acute appendicitis. Answer: B. Acute pancreatitis. Rationale: triglycerides greater than 1,000 mg per deciliter significantly increase risk of pancreatitis due to toxic free fatty acid generation in pancreatic capillaries. Strategy: for very high TGs, initiate measures to lower levels and monitor for pancreatitis, pain, lipase, may require insulin, fibrates, or plasmapheresis. Question 24. A patient on ACE inhibitor therapy has serum creatinine rise from 1.0 to 2.2 mg per deciliter within 48 hours of initiation. What is the likely explanation? A. ACE inhibitors protect the kidney immediately, no concern. B. Bilateral renal artery stenosis or reduced renal perfusion causing creatinine rise with ACE inhibitor use. C. Lab error. D. Hyperthyroidism. Answer: B. Bilateral renal artery stenosis or reduced renal perfusion causing creatinine rise with ACE inhibitor use. Rationale: ACE inhibitors can reduce glomerular filtration pressure by vasodilating the efferent arteriole. In patients with bilateral renal artery stenosis or volume depletion, creatinine can rise substantially. Strategy: if creatinine rises significantly after ACE/ARB start, notify provider, hold medication and evaluate renal perfusion/vascular disease. Question 25. A newborn at 48 hours has total bilirubin 18 mg per deciliter. What factor most influences the decision to start phototherapy? A. Baby's weight alone. B. Hours of life and risk factors per bilirubin nomogram. C. Maternal age. D. Mode of delivery. Answer: B. Hours of life and risk factors per bilirubin nomogram. Rationale: treatment thresholds depend on the infant's age and hours and risk factors, prematurity, hemolysis. A single bilirubin number must be placed on the age-specific nomogram to decide therapy. Strategy: always use age and hours nomogram and adjust for prematurity/illness before initiating phototherapy. Question 26. A critical patient's procalcitonin level is markedly elevated. How does this guide management? A. Suggests viral infection, stop antibiotics. B. Supports bacterial infection and can guide initiation/continuation of antibiotics when correlated with clinical status. C. Indicates autoimmune disease only. D. Is irrelevant clinically. Answer: B. Supports bacterial infection and can guide initiation/continuation of antibiotics when correlated with clinical status. Rationale: procalcitonin rises in systemic bacterial infections and sepsis and can help guide antibiotic stewardship when used with clinical assessment and trends. Strategy: use procalcitonin as an adjunct, not in isolation, trend it to assess response to therapy. If you're enjoying this video so far, like and subscribe. Welcome back. Question 27. A dialysis patient has K 6.4 milliequivalent/L with no ECG changes. Which is the correct priority? A. Wait and recheck later. B. Initiate measures to lower serum K immediately, insulin plus dextrose, binders, prepare for dialysis, and monitor closely. C. Administer oral K supplements. D. Give magnesium. Answer: B. Initiate measures to lower serum K immediately, insulin plus dextrose, binders, prepare for dialysis, and monitor closely. Rationale: K greater than or equal to 6.5 is an immediate risk, even at 6.4, dialysis patients are at high risk, treat proactively even if ECG normal. Interventions by time until dialysis. Strategy: prioritize life-threatening electrolyte derangements, K, use temporizing measures and coordinate dialysis. Question 28. A patient with chronic liver disease has low albumin, 2.0 g/dl, and ascites. Which physiologic mechanism explains the edema? A. Increased capillary oncotic pressure. B. Decreased plasma oncotic pressure leading to third spacing of fluid. C. Increased serum albumin production. D. Lymphatic blockage only. Answer: B. Decreased plasma oncotic pressure leading to third spacing of fluid. Rationale: albumin maintains oncotic pressure, hypoalbuminemia reduces intravascular oncotic pressure, promoting fluid shift into interstitial/third spaces like peritoneum. Strategy: consider albumin replacement, diuretics, and paracentesis as part of management depending on cause/severity. Question 29. A patient's serum ferritin is elevated but transferrin saturation is low. What condition fits? A. Iron deficiency anemia. B. Anemia of chronic disease/inflammation. C. Hemochromatosis. D. Acute blood loss. Answer: B. Anemia of chronic disease/inflammation. Rationale: ferritin is an acute phase reactant that increases with inflammation while iron is sequestered, low transferrin saturation. In iron deficiency, ferritin is low. Strategy: use ferritin plus TIBC/transferrin saturation to distinguish iron deficiency versus inflammatory anemia. Question 30. A patient's ABG, pH 7.21, PaCO2 28 mm of mercury, HCO3 11 milliequivalent/L. What is the primary disorder? A. Metabolic alkalosis. B. Mixed disorder, metabolic acidosis with respiratory alkalosis compensation. C. Respiratory acidosis. D. Respiratory alkalosis. Answer: B. Mixed disorder, metabolic acidosis with respiratory alkalosis compensation, acute. Rationale: low pH and very low HCO3 indicate metabolic acidosis, low PaCO2 indicates respiratory compensation. The degree of compensation is limited, but primary disorder is metabolic acidosis with respiratory compensation. Strategy: evaluate anion gap in clinical context, DKA, sepsis, renal failure, and look for mixed disorders if compensation doesn't fit expected formulas. Question 31. A postoperative patient's hemoglobin drops from 12 g/dl to 7.5 g/dl in 4 hours but vital signs are borderline stable. What should the nurse do first? A. Document and recheck in 12 hours. B. Assess for ongoing bleeding, check surgical sites/drains, obtain orthostatic vitals, and notify provider for possible transfusion. C. Encourage oral iron supplements. D. Nothing, patient is stable. Answer: B. Assess for ongoing bleeding, check surgical sites/drains, obtain orthostatic vitals, and notify provider for possible transfusion. Rationale: acute large hemoglobin drop suggests active hemorrhage even if vitals not yet decompensated. Identify source and prepare for transfusion if indicated. Strategy: rapid hemoglobin fall post-op mandates immediate bedside evaluation for bleeding and communication with the team. Question 32. A patient with suspected pulmonary embolism has D-dimer 1,200 nanograms per milliliter, elevated. What is the nurse's interpretation? A. D-dimer confirms PE definitively. B. Elevated D-dimer suggests clotting activity, further diagnostic imaging, CT pulmonary angiography, is warranted if clinical suspicion high. C. D-dimer rules out PE always. D. D-dimer indicates sepsis only. Answer: B. Elevated D-dimer suggests clotting activity. Further diagnostic imaging, CT pulmonary angiography, is warranted if clinical suspicion high. Rationale: D-dimer is sensitive but not specific, many conditions elevate it. Elevated level in appropriate clinical context prompts imaging to confirm PE. Strategy: use D-dimer to rule out PE when negative and to triage need for imaging when positive alongside clinical probability scores. Wells. Question 33. A patient with severe sepsis has lactate 5.8 millimoles per liter. Which of the following is the most important immediate nursing focus? A. Monitor only and wait. B. Initiate aggressive resuscitation, for fluids, oxygen, source control, and notify provider. Lactate indicates tissue hypoperfusion. C. Give laxatives. D. Start beta blockers. Answer: B. Initiate aggressive resuscitation, for fluids, oxygen, source control, and notify provider. Lactate indicates tissue hypoperfusion. Rationale: elevated lactate in sepsis correlates with hypoperfusion and worse outcomes. Early resuscitation improves survival. Strategy: treat lactate as a dynamic resuscitation target, track clearance to assess response. Question 34. A patient with chronic steroid therapy has fasting blood glucose 185 mg per deciliter and HbA1c 6.4%. How to interpret? A. Normal glucose control. B. Steroid-induced hyperglycemia. Consider monitoring and glucose-lowering strategies. C. Type 1 diabetes only. D. Hypoglycemia risk. Answer: B. Steroid-induced hyperglycemia. Consider monitoring and glucose-lowering strategies. Rationale: corticosteroids raise glucose, often causing postprandial hyperglycemia. HbA1c reflects average but steroids can cause variable spikes. Management may require insulin or oral agents per provider. Strategy: monitor glucose trends, fasting and postprandial, adjust therapy, and coordinate with provider regarding steroid dosing and glucose control. Question 35. A patient has serum ammonia 150 mol/L and confusion with hysterexis. What is the priority treatment? A. For naloxone. B. Lactulose to reduce ammonia absorption and treat hepatic encephalopathy. C. For potassium replacement. D. Emergent dialysis only. Answer: B. Lactulose to reduce ammonia absorption and treat hepatic encephalopathy. Rationale: elevated ammonia with neurologic signs indicates hepatic encephalopathy. Lactulose acidifies the colon and traps ammonia for excretion. Manage precipitating causes and consider rifaximin. Dialysis may be needed if severe and not responsive. Strategy: treat hepatic encephalopathy promptly. Lactulose is first line. Monitor mental status and ammonia trends. Question 36. A patient on total parenteral nutrition, TPN, develops hypophosphatemia after 48 hours. What complication is most directly related and must be monitored? A. Hyperactivity. B. Respiratory muscle weakness and possible respiratory failure. C. Hypersalivation. D. Hypernatremia. Answer: B. Respiratory muscle weakness and possible respiratory failure. Rationale: hypophosphatemia decreases ADP, causing muscle weakness including respiratory muscles, critical in TPN refeeding syndrome. Strategy: monitor respiratory status closely, measure serial phosphate, and replace phosphate as needed. Question 37. A patient with major GI bleed has lactate 4 millimoles per liter, BUN elevated disproportionately to creatinine. What does this pattern suggest? A. Chronic kidney disease. B. Upper GI bleeding with increased BUN from digestion of blood and hypoperfusion, prerenal. C. Nephrotic syndrome. D. Normal finding. Answer: B. Upper GI bleeding with increased BUN from digestion of blood and hypoperfusion, prerenal. Rationale: blood and gut increases BUN due to protein breakdown. Lactate elevation and high BUN/CR suggest hypoperfusion and/or blood digestion contribution. Strategy: correlate labs with clinical context, evaluate for ongoing bleeding, resuscitate, and correct perfusion. Question 38. A patient being evaluated for adrenal insufficiency has a morning cortisol of 5G/DL, low. What is the next appropriate diagnostic step? A. Start high-dose steroids immediately without testing. B. Perform ACTH stimulation test to confirm adrenal insufficiency. C. Ignore and retest in 6 months. D. Check TSH only. Answer: B. Perform ACTH stimulation test to confirm adrenal insufficiency. Rationale: low morning cortisol suggests adrenal insufficiency, but dynamic testing, ACTH stimulation, differentiates primary versus secondary and confirms diagnosis. Strategy: follow diagnostic algorithms. Abnormal screening leads to confirmatory dynamic testing before chronic steroid therapy unless crisis suspected. Question 39. A patient with suspected myocardial infarction has normal ECG but markedly elevated high-sensitivity troponin on serial testing. What does this indicate? A. Troponin elevation always false. B. Myocardial injury likely despite normal ECG, manages ACS based on trends and clinical picture. C. No cardiac issue if ECG is normal. D. Only pulmonary embolism causes this. Answer: B. Myocardial injury likely despite normal ECG, manages ACS based on trends and clinical picture. Rationale: troponin is highly sensitive, ECG can be normal early or in non-STEMI, serial trends and symptoms dictate management. Strategy: act on troponin trends with clinical context, order cardiology evaluation, antiplatelet/anticoagulation per protocol if ACS suspected. Question 40. A patient with suspected SIAD receives hypertonic saline. Which monitoring is most critical during infusion? A. Respiratory rate only. B. Serum sodium, avoid correcting more than 8 to 10 milliequivalent/L in 24 hours to prevent osmotic demyelination. C. Potassium only. D. Liver enzymes. Answer: B. Serum sodium, avoid correcting more than 8 to 10 milliequivalent/L in 24 hours to prevent osmotic demyelination. Rationale: rapid correction of chronic hyponatremia risks central pontine myelinolysis. Careful, slow correction with close sodium monitoring is crucial. Strategy: set hourly or frequent sodium checks and strict infusion protocols when using hypertonic saline. Question 41. A patient's ESR is normal but CRP is markedly elevated in the setting of acute inflammation. What is the best interpretation? A. ESR is always more sensitive. B. CRP rises and falls faster, it's more helpful for acute inflammation monitoring. C. Both tests are useless. D. Indicates viral infection only. Answer: B. CRP rises and falls faster, it's more helpful for acute inflammation monitoring. Rationale: CRP is an acute phase reactant that responds quickly to inflammation and infection. ESR is slower and influenced by other factors, age, anemia. Strategy: use CRP for short-term monitoring and ESR for chronic inflammatory states as appropriate. Question 42. A patient on warfarin presents with 9.2 Indian rupees but no bleeding. Which is the best immediate nursing action? A. Administer vitamin K per provider order and hold warfarin. B. Ignore because no bleeding. C. Give 4 heparin. D. Increase warfarin dose. Answer: A. Administer vitamin K per provider order and hold warfarin. Rationale: INR9 is high risk for spontaneous bleeding. Vitamin K reverses warfarin effect and reduces bleeding risk even if no active bleeding. Strategy: know reversal thresholds and act promptly to prevent hemorrhage. Question 43. A patient with suspected phenylketonuria, PKU, newborn screening returns abnormal. Which lab finding prompted this? A. Elevated phenylalanine levels in newborn blood spot. B. Low bilirubin. C. High TSH only. D. Low hemoglobin. Answer: A. Elevated phenylalanine levels in newborn blood spot. Rationale: PKU screening detects high phenylalanine due to PAH deficiency. Early detection allows dietary therapy to prevent neurodevelopmental damage. Strategy: for abnormal newborn screens, arrange confirmatory testing and early intervention referrals. Question 44. A patient's anion gap is calculated as Na 140, Cl 100, HCO 314. What is the anion gap and what does it suggest? A. Ag equals 26, elevated, suggesting an anion gap metabolic acidosis, e.g., DKA, lactic acidosis. B. Ag equals 10, normal. C. Ag irrelevant. D. Ag low. Answer. A. Ag equals 26, elevated, suggesting an anion gap metabolic acidosis, e.g., DKA, lactic acidosis. Rationale. Anion gap equals Na minus, Cl plus HCO3, equals 140 minus, 100 plus 14, equals 26. Normal 812, elevated Ag suggests accumulation of organic acids. Strategy. Use Ag to differentiate metabolic acidosis causes, then calculate delta gap if needed to detect mixed disorders. Question 45. A patient with severe sepsis shows procalcitonin decreasing from 12 nanograms per milliliter to 2 nanograms per milliliter after 72 hours of antibiotics. How to interpret? A. Worsening infection. B. Likely response to therapy, trending down indicates improvement, but correlate clinically. C. Unrelated to infection. D. Indicates viral infection. Answer. B. Likely response to therapy, trending down indicates improvement, but correlate clinically. Rationale. Declining procalcitonin suggests decreasing bacterial burden and response to antibiotics. Decisions should incorporate clinical status and cultures. Strategy. Use serial procalcitonin to aid in antibiotic stewardship and to assess treatment response, never as sole determinant. Question 46. A patient with alcoholic liver disease has prolonged PT/INR and low albumin. Which vitamin deficiency could contribute to coagulopathy? A. Vitamin C. B. Vitamin K deficiency due to malabsorption or cholestasis can worsen coagulopathy. C. Vitamin D only. D. Niacin. Answer. B. Vitamin K deficiency due to malabsorption or cholestasis can worsen coagulopathy. Rationale. Vitamin K is required for synthesis of clotting factors 2, 7, 9, X in liver disease. Deficiency or impaired activation exacerbates bleeding tendency. Strategy. Consider vitamin K administration and correct underlying cholestasis/malabsorption if present. Question 47. A patient has WBC 24000/L with left shift and bandemia. What is the best interpretation? A. Viral infection likely. B. Bacterial infection or significant inflammatory stress. Left shift indicates immature neutrophils released due to high demand. C. Normal variant. D. Chronic anemia. Answer. B. Bacterial infection or significant inflammatory stress. Left shift indicates immature neutrophils released due to high demand. Rationale. Leukocytosis with bandemia suggests acute bacterial infection or severe inflammation, correlate with vitals and source. Strategy. Seek and treat source of infection promptly, consider cultures and empiric antibiotics per protocol. Question 48. A patient on chronic hemodialysis has phosphate 7.5 mg per deciliter and calcium 7.2 mg per deciliter. Which chronic complication is most likely if untreated? A. Hemophilia. B. Secondary hyperparathyroidism and bone disease, renal osteodystrophy. C. Diabetes. D. Hyperthyroidism. Answer. B. Secondary hyperparathyroidism and bone disease, renal osteodystrophy. Rationale. Chronic hyperphosphatemia and hypocalcemia stimulate PTH and lead to high bone turnover and vascular calcification. Strategy. Manage phosphate with binders, dietary restriction, and treat secondary hyperparathyroidism per nephrology. Question 49. A critically ill patient's serum potassium drops from 4.2 to 2.7 milliequivalent/L after starting albuterol nebulizers and insulin for hyperkalemia. What is the priority nursing action? A. Nothing, this is expected. B. Reassess for signs of hypokalemia, muscle weakness, arrhythmia, monitor ECG, and replace potassium carefully per protocol. C. Give more albuterol. D. Start dialysis immediately. Answer: B. Reassess for signs of hypokalemia, muscle weakness, arrhythmia, monitor ECG, and replace potassium carefully per protocol. Rationale: rapid decrease in K can cause life-threatening arrhythmias and muscle weakness. Ongoing monitoring and careful replacement are required. Strategy: after treatments that shift K intracellularly, continually monitor K and ECG and be ready to replete. Question 50. A patient's BNP is 1800 pg/ml and presenting with dyspnea and crackles. Which intervention is most appropriate now? A. Start 4 diuretics and treat for acute decompensated heart failure per orders. B. Give 4 fluids bolus. C. Start antibiotics for pneumonia only. D. Ignore lab and send home. Answer: A. Start 4 diuretics and treat for acute decompensated heart failure per orders. Rationale: extremely elevated BNP with pulmonary crackles suggests volume overload/heart failure. Diuresis reduces preload and relieves pulmonary edema, correlate with vitals and oxygenation. Strategy: treat the primary issue, volume overload, promptly while monitoring hemodynamics and renal function. Use BNP trends to assess response. Great work making it through all 50 of these Nclex lab value questions. Remember, mastering lab values isn't just about memorization, it's about knowing how to interpret the numbers in the context of the patient's condition and deciding what to do first as a nurse. If you keep practicing this way, you'll build the confidence to handle even the trickiest Nclex questions. Don't forget to review these questions multiple times to reinforce critical concepts. Thank you for studying with me today. Stay motivated, keep practicing, and remember, every question you master brings you one step closer to passing the Nclex and becoming the nurse you're meant to be.